Hi all, and welcome to today's webinar on the in vitro measurement of drug bioavailability following subcutaneous injection. We will be discussing the history of the Pion SCISSOR and the founders of the technology that made the product possible. We'll review the anatomy of the subcutaneous injection site and how our approach can help you model events of the subcutaneous injection. We'll also briefly walk through the SCISSOR instrument and software to show you basic functionality. If you have any questions during this webinar, please submit through the Q&A button. Thanks, and welcome to our webinar.
In 2012, our co-founder John Comer attended the Formulation and Solubility meeting in Munich, where he met Randy Mersney, a professor at the University of Bath's Department of Pharmacy and Pharmacology. Randy was giving a talk on a review paper he was writing with his postdoctoral student Hanna Kinnunen, which was published last year in the Journal of Controlled Release. The paper identifies the need for new techniques which would enable developers to predict the in vivo fate of subcutaneously administered therapeutics. In it, they outlined their idea for a new instrument they had invented called SCISSOR, which simulated the physiological environment a molecule encounters upon injection into the subcutaneum. We were interested in Randy's idea and decided to collaborate in developing a commercial SCISSOR instrument. The vast majority of biopharmaceuticals are administered via parenteral routes. In 2012, there were approximately 210 marketed biopharmaceutical drugs. The majority of these were delivered through intravenous administration, and around 40 were administered by subcutaneous injection. For a variety of reasons, subcutaneous delivery is the route preferred by patients and healthcare providers. IV administration is time-consuming and requires the presence of trained medical professionals in order to administer safely. Intramuscular injections also require the presence of medical professionals and are renowned for being painful and uncomfortable. Subcutaneous injections are quick, easy, almost painless, less susceptible to infection, and are safe enough for self-administration, making them suitable for patient-managed home care treatments. Consequently, both academia and industry are looking at new ways to formulate existing biopharmaceutical molecules for subcutaneous delivery. Now let's look at the composition of the subcutaneous environment. The subcutis, or hypodermis, is a layer of tissue that is located between the skin and the muscle. The hypodermis is composed of a series of extracellular matrix components, which are primarily connective tissue, polysaccharide and protein molecules used in cell transport, and adipose tissue. The system is maintained at physiological pH by the body's carbonate-based interstitial fluid buffer, and the temperature is typically around 34 degrees centigrade, slightly below the core body temperature. Surprisingly little is known about the environment of the hypodermis, or how the transition from the conditions of a drug formulation to the homeostatic conditions of the hypodermis might affect the fate of an injected protein or peptide drug. So what are the common properties of the formulation that we are introducing into this environment? A biopharmaceutical product intended for subcutaneous delivery typically has a 2-year shelf life and is stabilized against the physical and chemical degradation that occurs naturally in these molecules over time. To this end, molecules intended for subcutaneous delivery are often formulated using non-physiological, biocompatible buffers to mitigate degradation. They are usually formulated in the presence of various stabilizing excipients to prevent undesirable phenomena such as self-association and aggregation on storage, and a small amount of preservative is normally present to prevent microbial growth. They are usually stored at low temperature to prolong shelf life. It's fairly apparent that the formulation conditions a biopharmaceutical is stored under bear little or no resemblance to the physiological environment it encounters upon injection into the sub-Q space. This being the case, it is unsurprising that formulations can behave quite differently upon injection. In the next few slides, I'll outline some of the events we might expect to see upon injection of the formulation into the hypodermis. After injection, the first thing that happens is the water diffuses quickly from the injection site in order to maintain a stable hydrostatic and colloidal osmotic pressure. If the molecule was formulated at low pH, a drop in pH at the injection site would be expected, followed by a gradual recovery as the body's carbonate-based buffer returns the system to homeostasis. During this period, depending on the behavior of the molecule and the excipients, there are a number of different ways in which the protein and excipients may reassociate with one another. These diagrams show 4 hypothetical scenarios that illustrate the potential reorganization of a protein in the presence of 2 excipients following subcutaneous injection. In scenario A, all the components remain associated in the same way within the ECM. In scenario B, excipient A is removed and excipient B associates more strongly with the protein. In example C, all the excipients leave and the protein aggregates, possibly forming a precipitate. Finally, in example D, the protein and excipient B are removed and excipient A aggregates in the ECM. This is, of course, an oversimplification, but it nonetheless serves to demonstrate some of the events we might expect to see upon the administration of a biopharmaceutical formulation. Unlike intravenous infusion, which is considered the most reliable method for delivering the optimal dose, the bioavailability of a dosage delivered by subcutaneous injection can be highly variable. This is, in part, due to the sudden environmental transition an SC formulation undergoes upon administration. To compound this problem, no animal model correlates to the in vivo outcomes observed in humans, and there is no technique for calculating the bioavailability candidates in vitro. What is required is an in vitro assay which simulates the various transitions a biopharmaceutical undergoes on injection, which gives an indication of performance in vivo. When conceiving of SCISSOR, 6 environmental transitions were identified that an in vitro model of the subcutaneous space would need to simulate. These include pH and how the pH would return to homeostasis after exchange with a bicarbonate buffer, the potential interactions a biopharmaceutical molecule might experience with the various ECM components, and how the excipients will redistribute following injection. The system would also need to mimic the temperature and pressure transitions a formulation would undergo in the sub-Q. By simulating these environmental transitions, we could better understand the behavior of biopharmaceuticals in vivo. To that aim, we created SCISSOR. And here's the finished product. The chamber is situated on the left-hand side. This is where the experiment is performed. The electrode and needle are housed in the top of the chamber lid, along with fittings for the CO2 line and inlet-outlet tubing going from the chamber and back via the manual sampling station, situated directly in front of the instrument. It is also possible to connect the sampling station to a Gilson autosampler. The lid of the chamber is removed between experiments to replace the buffer sink and the injection cartridge. The stand to the right, situated above the drip tray, gives the user space to place the lid while they do this. Along the back, there are a series of wash, storage and calibration solutions for the electrodes. This diagram shows a cross-section of the SCISSOR chamber during an experiment. A cartridge, which contains a simulated extracellular matrix, is held submerged in the center of the chamber, which is filled with 300 milliliters of carbonate buffer. The extracellular matrix is designed to simulate the injection site, and the carbonate buffer simulates the infinite sink of the body's circulatory system. Formulation is injected into the cartridge via a hypodermic needle, and pH at the injection site is monitored by a microelectrode. There are also a bank of LED diodes and detectors, which you can't see in this image, that shine light through the cartridge. Drops in light transmittance can be used to assess precipitation at the injection site. Once injected, molecules can diffuse out of the cartridge into the carbonate buffer sink through dialysis membranes housed in the walls of the cartridge. Fractions can be collected from the sink at different time points for offline quantitation. The resulting concentration time profile can be used to calculate a diffusion rate, which can then be correlated to in vivo uptake by the body. pH of the chamber is monitored by the chamber electrode and maintained at pH 7.4 by sparging with CO2 gas. Temperature is maintained by the heat plate and can be set between ambient and 50 degrees centigrade. The SCISSOR software is simple and intuitive. On the right-hand side of the screen there are two graphs. The top graph displays the chamber readings, the red line represents pH, and the green line represents temperature. The bottom graph displays the cartridge readings, where the red and blue lines represent pH and transmittance respectively. The countdown timer reminds the user when to take the next sample collection from the chamber, and the central pane above the timer describes the assay settings. This screenshot shows what happened a couple of minutes before and after the injection of insulin basal, a slow-release insulin suspension manufactured by Sanofi. Before injection, the transmittance and pH in the cartridge graph are stable, and the transmittance is around 100%. Upon injection, both the pH and the transmittance drop suddenly. Bear in mind that the pH drop is only very slight on account of the scale. Insulin basal is formulated around physiological pH, so we wouldn't expect to see much of a change. The transmittance drop is much more pronounced as particles of the insulin suspension obscure the light getting through the detectors. After the initial drop, the pH slowly recovers. It has been suggested that the initial drop could have been due to the presence of solvent-like excipients, such as M-creosol and phenol. These would have the effect of interfering with the electrode response, but as these components diffuse, the electrode response returns to its pre-injection values. This slide shows the same experiment 3 hours after injection. Here we see the pH initially recovered after the injection to almost exactly pH 7.4 before dropping back down again. The drop in pH after the initial increase might be due to insulin dissolving. At pH 7.4, insulin is above its isoelectric point and is predominantly negatively charged and more soluble. Crystalline insulin may be dissolving into solution at the injection sites to form negatively charged species, thereby releasing protons and reducing the pH. Transmittance remains low after 3 hours, indicating that the precipitate is still present and obscuring the detectors. We ran a series of experiments on two insulin formulations, insulin rapid and insulin basal. Insulin rapid is a fast onset, short-acting insulin designed to be taken just before meals to mitigate the increased blood glucose levels that manifest after eating. Insulin basal, as described in the previous slides, is a gradual onset, slow-acting insulin designed to be taken once or twice a day to maintain a regular level of insulin. The fast-acting rapid insulin is a solution. The slow-release basal variant is a suspension. We believed that the performance and behavior of the two forms would be easily differentiated by SCISSOR. Both formulations were injected into a cartridge containing 10 mg per ml hyaluronic acid, or HA. Light transmittance was monitored during the experiments, and fractions were collected from the chamber for offline analysis by HPLC. This graph shows the light transmittance data for the two formulations plotted against time following sample injection. Insulin rapid is the blue plot, and insulin basal is the red plot. The transmittance during the insulin rapid experiments remains constant at around 100%, indicating that all the material remained in solution for the duration of the experiment. The transmittance during the insulin basal experiment drops in stages as the suspended particles slowly sink and block more detectors. After approximately 240 minutes, or 4 hours, the transmittance starts to recover as insulin begins to dissolve. Finally, the graph in the top left of this slide shows the diffused fraction of insulin plotted against time. Once again, insulin rapid is coloured in blue and basal is in red. The diffused fraction can be used to infer uptake into the systemic circulation. In this case, almost all the insulin rapid has diffused within the first 60 minutes. The insulin basal, however, takes much longer to diffuse, achieving 50% diffusion within 10 hours. Interestingly, there appears to be an inflection point around 240 minutes, where the rate of diffusion increases. This aligns well with the recovery in transmittance in the previous slide, where the basal started to dissolve into solution. When we compare these diffusion profiles against published human PK data, we can see that the diffusion rates and the onset, peak, and duration profiles agree with one another. But insulin is a relatively small molecule in the biopharmaceutical space, with a molecular mass of around 6 kilodaltons. This flowchart illustrates one possible example of a development cycle for a subcutaneous formulation. Once the lead API for a particular target has been identified, the drug candidate enters formulation development. The process of formulation development includes a variety of stability studies before progressing to clinical trials. The problem is that, up until this point, all the tests undertaken are not designed to give any indication of performance in vivo, so animal testing is currently the only means of predictive testing for human bioavailability. But animal testing is not always that good an indicator of human in vivo performance. Once we get to the clinical trial stage, an ideal scenario would be for one or more of the formulations tested to show promising results and can then advance to late-stage clinical trials on the way to becoming a marketed drug. Alternatively, if all formulation candidates perform poorly on animal testing, this can result in the program being killed, even though animal trials are often poor models for in vivo performance. For example, interferon alpha has low bioavailability in animals, but very good outcomes in humans. This could mean that projects which have been abandoned on the basis of poor clinical animal trial performance may have been terminated prematurely. But the opposite can also occur. Some or all of the formulations may perform well in animal testing and are then progressed to human trials. If they perform poorly at this stage, however, it is almost always the case that the program is terminated. Human epoetin beta is an example of a molecule that exhibits this characteristic. It has high bioavailability in animal models, but has very poor outcomes in humans. What's missing is a predictive tool that can help screen candidates to give an indication of human in vivo performance before clinical trials. To sum up, we envisage that if SCISSOR was employed during formulation development and lead formulation selection, it could provide important information on the formulations being tested. This would allow developers to rationally select excipients that improve the molecule's performance, thereby lowering failure rates and expediting the progress towards a marketed drug. Animal testing would only be used for toxicological studies, and candidates selected for human trials could be based on stability data and SCISSOR performance, thus reducing the cost and time associated with animal testing and reducing the prospect of terminating projects late stage. I hope you've enjoyed this presentation and the introduction to SCISSOR. We've identified the need within the biopharma industry for more in vitro testing of formulation performance for SC formulations and demonstrated how SCISSOR can be used to understand injection site events and give users a means of predicting outcomes in vivo. Finally, we looked at how SCISSOR could be employed by the biopharmaceutical industry to help improve formulation development. Thank you all for listening.